Okay, well, delighted to see everybody here today. Kathleen has actually just presented a study from the same sample that I'm going to talk about today. So if you can imagine a kind of segue into this presentation, this is also from the Concordia Longitudinal Risk Project in Montreal. We're going to take our presentation one step further now. You've heard about the life course, some of the early adulthood life course outcomes from aggression in Kathleen's presentation, some fairly obvious ones towards aggressive behavior in its adult form, criminality. Now we're going to take an intergenerational focus, because in our sample we actually have 3 and now increasingly into 4 generations of people from low-income neighborhoods in Montreal. And that's the sample Kathleen worked with and that I'm going to report on. And here we're looking at intergenerational patterns in the transfer of risk. Once again, we're taking a protective, preventive approach. So what we're looking at is risk factors and also protective factors. But in this case, we're going to focus on prevention of intergenerational outcomes from childhood aggression. And I should mention that after I finish presenting on this part of the study, Dale's going to give, Dale Stack, who's right there, is going to give a general discussion of specific to this project, and then just talk a little bit about the implications of the Concordia project results for this conference. So let me go to our first slide. So we know that childhood aggression has long-term consequences for the aggressor. There are long-term effects that are associated, in addition to what you just heard about of criminality. There's a large literature suggesting that it is associated with neighborhood disadvantage in adulthood. Aggressive children do not grow up to have very good outcomes. That's what we're saying. It's associated with family dysfunction, with poor mental and physical health, with a poor employment history, frequent unemployment, frequent job changes, low income, and so forth, and with criminality. We also know that there is an intergenerational cycle. There's a literature that focuses on how early aggressive behavior may predict later parenting conditions and family contexts. For example, earlier parenthood, teen parenthood in aggressive children, particularly girls, boys as well though. It predicts single parenthood, okay? And it predicts lower family income. All of these are negative conditions for parenting, for parenthood, for the next generation. So we're beginning to see how an intergenerational cycle occurs. And consequently, we see effects on the offspring of aggressive children in terms of health and development. Now we're talking about early health and development for offspring, and that's what I'm going to focus on today. So why would parents' history of aggression predict the early health and care and health care given to their offspring? Well, there are two general pathways we're going to discuss today. The first is via continuing a behavior pattern from childhood, which would involve, as you can well imagine, abuse, neglect. Children become injured, and through the neglect they may be sicker. All right? That's fairly logical, fairly straightforward. However, there's also what we call the cascade model, which takes us back to maybe perhaps closer to Bronfenbrenner's multi-system approach. And in this, we look at how childhood aggression leads to a lack of resources in adulthood as these new families are being formed. And so there's a sequence of negative effects which impact the early health of young children. These include what you just saw a moment ago with Kathleen's presentation of lower education, but also early parenthood, so age at which you become a parent, and things like your family and your neighborhood disadvantage, all of which are going to affect the early health of children. So if childhood aggression leads to those things as you become a parent, those in turn become mechanisms affecting the health of young children. So our research questions today will focus on 2 generations, the parents, who we're calling G1, and the offspring we're calling G2. The first question will be, does a pattern of aggressive behavior in the G1 parents' childhood predict lower quality health care and poor health outcomes for their G2 children? The second is, what is the process? Is there a cascade of negative effects from aggression in childhood over time, leading to negative health and care outcomes for offspring? And the third, what are the protective factors that may predict positive outcomes despite G2 risks? And Kathleen's already given you a preview on that. Okay, so the sample, I won't go into methodology much because you've just heard from Kathleen. We used 2,865 families in the Concordia project. These are the G1 parents and one of their G2 children. The eldest, typically the eldest, in some cases it was a younger child because we needed to have an age range between 1 and 6 years within our data set to run these analyses. So the G1s were recruited. I don't know if does this work as a pointer? No. Okay, so here we go. Yeah, the G1s were recruited 40 years ago now, when they were aged 7 to 13 from lower income districts in Montreal. And their G2 offspring were born anytime from about the late 80s up until about 2000, so that we had 6 years worth of their data up to age 6 by 2006, when we drew these data from the Health Ministry's archives. So the predictors in the study, I'll go very quickly because you've seen them already. Thank you. Parents' childhood history of aggression. Yeah, okay, you've seen most of these, so I'm going to go very quickly through them. The one thing I will show you is the control variables, one of which is new. We controlled for the parent's health history in these analyses, the rate at which the parent had medical visits during 3 years before the child was conceived, so before 9 months before the child's birth. And this is to control for both similarities between the generations and actual health, how often you get sick, and also patterns of seeking medical assistance. So that's a very important control when you do this. And all of these data were taken from health records, objective health records from the Ministry of Education. We have a universal care system, so every visit to the doctor or to any medical facility is recorded, and we had access to all of those comprehensive records back to about 1981 for the parents, actually, but we didn't need them quite that far back, considering the age of the children. Okay, so let me go on. These are our outcome variables. It's between ages 1, 12 months, and through age 5, 6 years. From administrative records. We looked at annual rates of emergency and non-emergency medical visits, quality of care, which is a very interesting variable in the prevention literature, which is the ratio of emergency room visits over above the total number of visits. In other words, if your kid got sick, where did you take them for care? Did you go to the emergency room or did you see an outpatient clinic? And the emergency room, of course, means the kid was either sicker or you weren't organized enough or didn't have the resources to make an appointment to see the doctor, to see the pediatrician or whatever. So it's a quality of care measure that's very widely used in epidemiology and public health. All right, and the last we have frequencies of injuries and infections, annual frequencies of the children. The first thing I'm going to show you is a very simplified version of a regression model. Here we're controlling for all kinds of things: child's gender, parent's health history, and the parent's childhood disadvantage, or SES. And what you can see is that childhood aggression for both the mothers and the fathers is predicting quite a few of these outcomes. It negatively predicts non-emergency visits. Isn't that interesting? In other words, people with a history of aggression do not take their children for well baby appointments very often. I find that quite striking. On the other hand, when you talk about emergency room visits, it's a positive relationship, more emergency room visits. And then the kind of critical issue of quality of care, percentage emergency visits over total, again, for both the fathers and the mothers, you see that there's a positive relationship between relative proportion of emergency room visits for people with a history of childhood aggression. Now you'll also see it with emergencies that were seen outside of with injuries that were seen outside of the emergency room. It's only marginal for women, only for the emergency room injuries, and that's because those are mercifully low frequency. Okay, children don't end up at the emergency room with injuries that many times a year, thank goodness. Then you don't see it for infections. Infections are any kind of illness that was caused by an acute infection, and you do see it for children being brought to the emergency room with an infection. That could be a neglect. It could be I wait till my kid gets very sick before I go to the emergency room kind of phenomenon. So the next thing I'll address here very quickly is the path model that we did to look at this cascading. And to make it quick, we put it in red for all of the mediated pathways from childhood aggression. We gave you only one of the outcomes. The models are close to identical for all of the outcomes. All right, so here's proportion. This is the quality of care. Use of the ER, thank you. Use of the ER. And what you'll see is that childhood aggression in this mediated model, they are only for the females. The females are on the left in this case. It doesn't exist for the males. Everything is mediated for the males. For the females, most of it's mediated. There still is a direct effect of aggression, but it's only marginal. But what you get is that childhood aggression is predicting younger parenthood. Young parents, in turn, are making more use of the emergency room. Okay, so it negatively predicts older parenthood. Older parents make less use of the emergency room. That's probably the simpler way to put this. Okay. Similarly, childhood aggression is predicting for both males and females years of education. You saw that in Kathleen's production, negatively predicting years of education. Years of education, of course, is protective. Older parent, you become a parent at a more mature age, and you can see the pathway from there. Similarly, aggression goes into education, and that leads to current neighborhood disadvantage, controlling for childhood SES here, okay, which of course is predicting current neighborhood SES. But you see this pattern via years of education, and then high neighborhood disadvantage predicts more use of the emergency room. In poor neighborhoods, there's more use of the emergency room. So we see the cascade model here. Right? I'm going to turn the microphone now over to Dale, who is going to discuss these results and the next steps. Here you go, Dale. There's your summary, and there's your pointer.
Whoops, that was a good start.
Oh.
Well, I made a splash. So, we will ignore that for the moment. Sorry about that. Okay, so the first thing I want to do is talk a little bit about some of the findings and summarize the findings before going into some of the implications for bullying, and also bring it back to some of the resources on bullying that we have in Canada. So the first thing that you've learned from what Lisa described first is that parents' childhood aggression indeed does predict early children's health and health care. Thank you, Anders. I'm sorry.
It's okay.
What a way to see a Canadian on stage, right? No, that's right. Thank you.
That's all right.
Secondly, what we also learned was that there's this behavioral continuation that's occurring. And by that I mean you're seeing it from childhood to adulthood. That can be through, from some of our other findings, abuse, neglect, disorganization, and unsafe or poorer parenting practices. Thirdly, you saw this cascade that Lisa spoke about. And that is that you saw the mediated paths from early childhood aggression to the outcomes on child health through lower education, earlier parenthood, greater disadvantage in the neighborhoods that these children were reared. Fourthly, that both parents play a role in determining the quality of health care. But as you saw from that table that Lisa presented, more so for girls. In other words, girls who were high in aggression when they were children and now are mothers. And in this intergenerational context, you saw that that made a difference. So these results illustrate what we believe to be rather complex, a complex developmental web that's intergenerational in nature and reflects cycles not only of health, but also of education, environment, and poverty. So what are some of the policy implications? What are some of the opportunities for us to break this cycle? One is, and I'm sure some of these are very familiar to all of you in your respective countries, we need to provide more support to at-risk families. But if we want to do that, we need to provide preventive intervention. We need to focus on reducing aggression, easy to say, perhaps harder to do. We need to improve social skills and, in particular, emotional competence. We need to improve academic and cognitive skills and support. Preventing school failure. Wanting these children not to drop out of school early. We can see how important education is in both Kathleen's and our presentation in these very high-risk children. And we also want to be able to avoid early parenthood. Keep children in school, keep children from not becoming parents too young. Fifthly, we need to provide support. But that support is not just financial in terms of material resources, it's also in terms of social kinds of support, access to services, and ability to get to those services so that young parents can provide quality health care for their children. But in a universal healthcare system that we have in Canada, yes, it's accessible, but how accessible is it to these high-risk families? Are they able to navigate the kind of networks that they have to be able to do to reach those services? So that's another reason why you want to focus on the quality of care, that continuity of care, and not forgetting about accessibility. If we want to do that, we need to do it particularly so for low-income neighborhoods, helping them navigate the system, letting them know that there are CLSCs, and what we call them in Quebec, but these health clinics that you can go to, where you can see pediatricians, where you can get the kind of continuity care, and you don't need to rely on the emergency room visits. And our healthcare system wants that to happen as well, because emergency room care is, first of all, very expensive, second of all, you have to wait a long time, and third of all, you're not going to see the same person. You'll get your needs met at that one time. So what are some of the implications? Now, this is a busy slide, but I know that some people like to take pictures, so I wanted all of the text on there, but I'm going to speak to a few points. How many minutes do I have? Good. Thank you. So we can see and we know from prior research that there is this stability of aggression. We also know that aggressive individuals, not only is it stable, but there's also repeated patterns. We also know that those repeated patterns are true for bullying. So when we think about childhood aggression and children who were highly aggressive and become parents, what do we see? So we've seen that there's higher levels of criminality. We've seen that there are environmental and economic stressors, so the conditions within which children grow up in. Some individuals are able to circumvent that adversity, and that's what we're interested in studying. Others are not able to do so. And that leads to a distress in parenting. Although we didn't present that work today, I want to share just a little bit with you. What is distress in parenting? Well, for example, it's higher levels of parenting stress, lower levels of social support, higher levels of poverty. How does that play out? Well, it can play out in terms of less cognitive stimulation to children because of the fewer resources, less time. It can also lead to parenting behavior, which many of you are aware of. So we know from our own research those can play out in terms of lower levels of maternal sensitivity, higher levels of harsh discipline, higher levels of hostile parenting, lower levels of cognitive stimulation, and family violence plays into this picture. So interparental violence that can model aggressive behavior for the young offspring. Thankfully, it can be offset by some available buffers. And as I said earlier, some families can circumvent this adversity, and we want to know what are the factors that allow for that. So things like social and economic support, the coping ability, the positive dynamics of parenting, and education and likability. So to conclude, This problematic pattern of aggressive behavior over time that in some cases remains stable contributes to this evolving picture that has been described by a number of us today and certainly in the conference itself, in the complex and sort of reflects the complex ways with which aggression, maladaptive behavior, environmental risk, and familial conditions place children at risk for problematic health, as well as, of course, ongoing problems. And that indeed also suggests this relationship between bullying and family violence. And before I end with acknowledging a number of people, I also wanted to mention our network in Canada that myself and Lisa are a part of, that the two scientific co-directors are Deb Pepler and Wendy Craig. And this is promoting relationships and eliminating violence, prevnet.ca, and it's Canada's authority on research and resources for bullying prevention. And here what we do is we have a large group of researchers across Canada, and as many of you know, Canada is a very large physical space, but a very small population. So the mission of PrevNet is to really try to change the social fabric of Canada, to try to reach out to every child and family, which, yes, is a very loud and hard goal. But in order to do that, you need researchers, you need non-governmental organizations, and you need graduate students, postdoctoral fellows, the next generation, shall we say, of people on the front lines. And we do that through sports groups, through camps, through reaching out to Girl Scouts of Canada, Boy Scouts, and so on. So all of this to say, I want to thank the funding agencies that certainly have been able to provide the financial resources for us to continue this research. And I want to send out a big thank you to the Concordia Longitudinal Research Project participants, without whom, over 40 years of data collection, we would not be here today. Thanks very much for your time.